Hey, good morning. Okay, good morning, everyone. Sorry for the small glitch. I think everybody will join in later slowly. Tapi kita start dulu lah. Good morning and welcome to the Neuro Emergency webinar series. So, this Neuro Emergency webinar series is part of the program of development of Neuro Emergency Special Interest Group to bring awareness and improve our knowledge on a wide sector of neuro emergencies or neurologic conditions that we deal with daily, to learn the approach from experts to improve our quality of care in neuro emergency, one of the initiatives under Neuro EM SIG. Without further ado, our topics today will cover myopathies and spinal cord injuries and these autonomic dysfunctions in spinal cord injuries, things that we see on a daily basis. So every day we see these kind of cases. Example, myopathy. Maybe we will send the electrolytes and trace the electrolytes and try to refer based on electrolytes. Kan? Or maybe we have patients with spinal cord injuries and sometimes we see autonomic dysfunctions, but we don't know exactly what happens to the patient or what was the critical care aspect in the rehabilitation of these patients. And knowing that can improve our patient management as well. All right. So without further ado, I would like to introduce our first speaker. So the topic of the first talk today will be understanding autonomic dysfunction in spinal cord injury survivors by Dr. Mohaneshwary and Sandra. So, just give me a second, sorry. So, Dr. Mohaneshwary and Sandra is a consultant rehab medicine physician in Hospital Serdang. Areas of expertise include neuro rehabilitation and spinal cord injury rehabilitation, cardiopulmonary rehabilitation, amputee and musculoskeletal rehabilitation. She is heavily involved in education and training as well. She's got her MD from Volgograd State Medical University of Russia. Then she pursued her master's in rehab medicine in University of Malaya in 2017. So, she has done a subspecialty fellowship in critical care rehabilitation, post-transplant rehabilitation, and neuro rehabilitation. So very relevant to our neuro EM field here, from the UK and Malaysia. She's got professional affiliation with the Malaysian Association of Rehab Physicians, member of International Society of Physical and Rehabilitation Medicine. She's an active collaborator in national rehab initiatives, okay, which includes neuro, spinal, and cardiopulmonary rehabilitation, and heavily involved in clinical training and patient education. So it's an honor for us to have such a distinguished speaker. So I pass over to Dr. Mohaneshwary and Sandra. Please proceed. Thank you.
Good morning, everyone, and good morning, Dr. Gurmit. So thank you for the very kind introduction. Everyone can call me by Anis. So I've been working in Hospital Serdang since 2017. And very thank you actually to the Emergency Physician Society for inviting me to speak today. I hope it can be an informal session and we can have our Q&A at the end of the session. All right, so I'll just share my slides first. All right, everyone can see my slides?
Yes, we can.
Okay, all right. So the topic given to me was actually understanding autonomic dysfunction for emergency physicians. So basically, this autonomic dysfunction is a huge umbrella term, but where I will specifically speak about autonomic dysreflexia, which is a part of the autonomic dysfunction. So autonomic dysfunction actually comprises of autonomic dysreflexia, which I will explain in detail today, thermoregulation, and also the orthostatic hypotension. So orthostatic hypotension, thermoregulation, dysregulation, we do experiencing patients having this, but it's not one of the very important or critical emergency, I would say, in medical field. Whereas this autonomic dysreflexia is actually a condition, although very specific to spinal cord injury survivors, but they often present firstly to emergency department. So over the next hour, we'll look at why this condition matters, how to recognize it quickly, and how early management actually can save lives. Yeah. All right. So objectives of today's talk will be at the end of the session. Everyone should be able to understand the autonomic nervous system and the role in blood pressure regulation, to define and recognize autonomic dysreflexia, which is always commonly known as AD. All right, so I will be mentioning AD throughout my talk today, and to also understand the pathophysiology and common triggers in SCI survivors causing this AD. Lastly, also the how to manage it in the emergency setting, and also for prevention strategies and teamwork approach with rehabilitation team. Yeah. All right. So I'll start with a case scenario. Imagine one of you all are getting a call, actually for, and this is a typical ED presentation. Yeah, 35 years old male with a C6 spinal cord injury. I would say complete C6 spinal cord injury, who presents to ED, complaining of sudden pounding headache and also facial flushing. So his blood pressure is about 200 systolic over the diastolic, which is 110, and heart rate of 48. There's no chest pain, no neurological deficits. So what would all of y'all do first? Maybe can I get some answers, feedback? What would y'all do? Anyone wanna start, or shall I just proceed? All right, so no worries. Basically, this could be mistaken as for anxiety or even a hypertensive crisis. But in spinal cord injured patient, it's most likely autonomic dysreflexia. So what is autonomic dysreflexia? It's AD, known as AD. It's potentially a life-threatening emergency. So it commonly happens with SCI survivors at the level of T6 and above. Whoever sustain an injury of T6 and above, they can have this. But there are also reports where cases reported who spinal cord injured patient as low as T8 to T12. So not necessarily T6 and above definitely to have this, but there are also cases reported with T8 and T12 injured patients as well. So it's a medical emergency where basically increase in both systolic and diastolic blood pressure. So this is very occasional and classically described with associated bradycardia as well. So although tachycardia can be present in the beginning, but later on it will be the patients will be having bradycardia, as the case scenario that I mentioned earlier. So because of the patient having most of these what do I say, like spinal cord injured survivors, especially the high thoracic or cervical spinal cord injured patients, they usually have low resting arterial blood pressure. So please keep in mind, their blood pressure is always less than 100 for the systolic, and diastolic can be less than 90 or even 60 to 80. Yeah. All right. So any increase in blood pressure, the diastolic or even the systolic, greater than 20 millimercury mmHg, can be indicative of episode of AD. So what causes this? It can be triggered by noxious stimuli. So any noxious stimuli below the level of spinal cord lesion. So when there's a trigger below the level of spinal cord lesion, they can have AD. All right. So what's the epidemiology and what's the relevance? As I mentioned earlier, it's a life-threatening emergency unique to SCI, T6 and above, and incidences are about 90% with complete SCI at T6 above. And it usually they can be encountered in ED or even during in the ward inpatient during the acute episode. So delay in recognition can actually lead to a very catastrophic conditions such as strokes, yeah, hypertensive because of hypertensive crisis, stroke, seizure, myocardial infarction, and even death. So early identification and management is very crucial and critical. Whereas in our Malaysian context, so SCI incidences are rising due to road traffic injuries, and but unfortunately, a lot of tertiary hospitals do face under recognition of this AD. And it is very common, about 60 to 70% of cases with high cervical injuries actually can have AD. Whereas patient with complete SCI, in the first year, they can have about 15 to 20% of those patients also experience AD in the first year. So very important for all the EPs to be aware of this and also communicate with the rehab team because very essential for the patient survival. So a quick overview of our autonomic nervous system. Of course, this is, going back to physiology for a moment, which we all learned or we memorized basically in our medical school. So I'll just brief through a quick one. Basically, nervous system, we've got our central nervous system and peripheral nervous system. Central is being controlled by this brain and spinal cord, whereas the peripheral nervous system, it is a structure outside of the brain and spinal cord, which further divides into autonomic nervous system and further divides where is sympathetic and parasympathetic. Yeah, so it's a parallel system where it's actually being controlled by sympathetic and parasympathetic. So if you look back to our medical school, or which we all know, so sympathetic we all know it's for fight and flight, whereas parasympathetic is for resting. So it controls when control our resting moment and more of our digestive system. So it actually restores the calm. Both are normally balanced through input from the hypothalamus and brainstem. So understanding this balance will make it easier to see why everything goes wrong after a high spinal cord injury. Yeah. Okay. So if you go to this, you can see comparison. I've shared here comparison between the sympathetic and parasympathetic system. So basically, sympathetic system increases heart rate, blood pressure through the norepinephrine release, whereas the parasympathetic reduces the heart rate, digestion, controls digestion, relaxation, pupil constriction through the acetylcholine receptors. So this balance interaction between these two basically maintains homeostasis. So when there's a imbalance, this is when the whole body goes into a haywire condition. All right. So importantly, to our topic today, autonomic system actually mainly regulates our blood pressure. So blood pressure is affected by two things: is our cardiac output and also our peripheral vessel resistance. So looking to this system, sympathetic and parasympathetic, which affects the peripheral vessel resistance. So this is the picture. If you all, it's a flashback where our basically brain, our medulla system, and then the spinal cord. So you can see there's, as I mentioned earlier, sympathetic and parasympathetic is a parallel pathway. So it affects our aortic arch. There's this aortic arch. So there's a lot of baroreceptors in our aortic arch and also our carotid sinus. So looking into the next slide. Okay, so when there's baroreceptors, as I mentioned earlier, in our carotid sinus and aortic arch. So what they do is they sense there's a blood pressure changes. So when there's increase in blood pressure, automatically the parasympathetic system being activated. So your vagal tone being activated, leading to reduce in heart rate, vasodilation, and reducing sympathetic tone. But when there's a decrease in blood pressure, automatically your sympathetic flow outflow will be activated, leading to vasoconstriction and increased heart rate. So just remember these two systems and its effect. So you will basically able to understand the AD. So when there's a spinal cord injury above the T6, it basically disrupts the descending inhibitory control of the sympathetic system. So this is where this diagram, all right. So number one, when there's a stimulus, as mentioned earlier, a noxious stimulus below the lesion. So below T6, there's a stimulus or there's a noxious stimulus. What it does is, it basically example distended bowel or bladder. So what it does is, it activates the efferent stimulus, and then leading to massive sympathetic response. So where I mentioned earlier, sympathetic leading to vasoconstriction, right? So it has a widespread vasoconstriction, causing in increased in elevated in blood pressure. So when this blood pressure that's elevated in blood pressure, our baroreceptors actually the stretch reflex and baroreceptors in our carotid arch, in our blood vessels, they detect the elevated blood pressure and they send a signal to the brain through our cranial nerve 9 and 10. So what does the brain send? Basically, brain senses it and sends an input through cranial nerve 10 to reduce the heart rate. So when this is our normal regulation system, but because the descending inhibitory signal is blocked at T6 because of spinal cord injury, this heart rate to being slowed and to send a signal to the below injured level to actually reduce the blood pressure does not get sent. There's a blockage. So what happens is, there's a persistent hypertension. So normal body, when there's an elevated blood pressure, the signal being sent down and your parasympathetic takes over to reduce your heart rate, to reduce your blood pressure. But when there's a blockage in our spinal cord, so the inhibitory control is being blocked and leading to persistent hypertension. All right. So why T6 and above? So the answer is basically at our T6 level, there is where the main control of our splanchnic sympathetic outflow. So if you have our greater splanchnic system and our lesser splanchnic vessels. So to know if many of y'all, forgotten this physiology, our splanchnic system is basically regulates our 1/3 of our blood volume to control our blood pressure. So imagine when there's a lesion above T6, patient basically lose control, leading to massive vasoconstriction and then increment in blood pressure. Whereas when, as I mentioned earlier, some patients below T8 to T10 or T12, they can have some mild AD because due to the lesser splanchnic system. So they do have some retained partial inhibition, and this leads to mild AD, or many of them don't even experience AD. So when the splanchnic circulation, there's vasoconstriction, constant vasoconstriction, it leads to great change in our blood pressure system. Yeah. So as I mentioned earlier here, T6, I think the line has moved. So it's actually at T6. Sorry, the arrow has moved. So it's at T6, lesion at T6. Okay. All right. So as I mentioned earlier, AD. So you have symptoms based on our splanchnic vasoconstriction. Patients can have pallor, piloerection, or cold extremities. Whereas above the lesion, they can have sweating, they can have headache, flushing, and nasal congestion. So as you can see, there's two arms. Just look at the lowest arm there. So this is how you basically divide your symptoms. So, all right. If you all can see this, but below the lesion, here on the green on the right side, they can have pallor, piloerection, goosebumps, or cold extremities below the lesion. But whereas above, many of them present with sweating, headaches, flushing, and nasal congestion. So it's just total opposite symptoms happening in their body. All right. So what are the common precipitants? We just look into the common one. There's so many precipitants, but common is always common. So urogenital, as they all have neurogenic bowel bladder. So many of them, they might have bladder distension. They come in with bladder distension or due to blockage of the catheterization. Another common thing is urinary tract infection. And least common, but we do realize, we do see these cases quite commonly nowadays, menstruation in the female spinal cord injured survivors. Whereas the GI system commonly is bowel distension due to paralytic ileus or constipation, or even some a lesser degree who having reflux GERD, and commonly also hemorrhoids. Okay. Whereas skin is the third most common precipitant, pressure injury. So many of them, they can go back and then they develop a new pressure injury and then they come in with AD. So look into that. And then ingrown toenails, which is, we might look in, take it into very, it's not serious, but actually ingrown toenails do cause AD for many spinal cord injured survivors. Constrictive clothing as well. Many of them like to wear tight jeans or do cause AD. Whereas whereas into the MSK system, you please look into heterotopic ossificans. So this can be diagnosed by X-ray or fracture. Yeah, so these are also common things when the patient, let's say you have ruled out urogenital, you have ruled out GIT scheme, please look into fractures, heterotopic ossificans, or even a DVT. All right, so this is through further imaging that we can identify the etiology. So as I mentioned earlier, the clinical features, they will come in with sudden hypertension, 20 mmHg above the baseline. So do ask patients if they know what is their baseline blood pressure. Most of them are aware of that. They will have a pounding headache, facial flushing, sweating above the lesion, as I mentioned earlier, bradycardia, nasal congestion, blood vision also above the lesion. Below lesion, they can have pale, cool skin due to vasoconstriction and goosebumps, piloerection. So always have differential diagnosis when they come to, of course, when they come to ED. So common differentials that we all have to keep in the back of our mind is ED, just get the history. They've got spinal cord history. Yes, you tick that. So you know the triggered factor. Is it episodic, meaning it's not constant? And they've got flushing, they've got sweating, headache, piloerection below the lesion. So it's AD. Whereas pheochromocytomas, they is paroxysmal. They can have sweating, palpitation, but no spinal cord injured history. Hypertensive emergency, same. They come in with progressive and organ signs, symptoms. No spinal cord injured histories as well. Preeclampsia, please don't forget this. But in preeclampsia, usually, of course, obvious history is pregnancy. And when you do a urine dipstick, they've got proteinuria. And they don't have spinal cord injured history as well. Okay, so we are looking into, we commonly use this guidelines for our evaluation and management, how to manage autonomic dysreflexia and other dysfunctions. So I would just like to emphasize this BP threshold in our spinal cord injury patients. So as I mentioned earlier, the higher cervical injury patients, or even higher thoracic, their blood pressure, as I mentioned earlier, you see, the systolic blood pressure, average 110 or 100 in a supine position, whereas in seated, it will be always 10 to 20 systolic blood pressure lower, which is 100 mmHg. Yeah. So please remember this blood pressure. So very important for you to diagnose AD. So when at supine level, if their blood pressure is more than 130 and 140, it's definitely AD. Whereas at seated position, if their blood pressure is more than 120 or 130, it's definitely also AD. So just remember, increment of 20 to 30 mmHg from the baseline blood pressure equals to AD. Okay, so this is a very busy slide, but this is the basic algorithm for AD treatment. So you can see this where patients with T6, they present to AD, they've got some symptoms, and then you have the checklist. So if you see that the patients, let's see if they come in with some abdominal binder. So many of them have that, or they wear tight stockings. So please loosen all their clothings. Okay, loosen all the clothings, and then you see whether they've got indwelling catheter or they've got a suprapubic catheter, whether it's kinked, not kinked, and then if it's kinked, you release the kink, and then after that you check the blood pressure. So when they present to ED, you need to monitor blood pressure every 2 to 5 minutes. So if the blood pressure is not improving despite settling the bladder issues, So you look into the next cause then, which is commonly the bowel. When you look into the bowel issues, so commonly is impaction, yeah, commonly is impaction. So if there's impaction, of course, then you have to evacuate. So before evacuating, there are a few steps that I will mention in my next slide, how to do a bowel impaction clearance. So first, bladder, look for the triggers. Second is bowel. Then third is skin system. So you look for any pressure injuries, you look for any ingrown toenails. So while you are doing this, please don't forget to monitor the blood pressure every 2 to 3 minutes. So if the blood pressure is more than 150, please stop any of those that you are looking for. That means for the bladder, for the bowel, you need to start the pharmacological agents. So which I will explain in later. What are the pharmacological agents? So remember, for in ED, when the patient comes with high blood pressure for AD, it's important to sit the patient upright, not lying down like what we usually do. So you need to sit upright because this causes the pooling of blood vessels, pooling of venous pooling in the lower limb. So which leads actually to low blood pressure. So it's the orthostatic. We want to induce the orthostatic hypertension. So this is very, very important, and not lie the patient flat. Loosen all their tight clothings and look into the each system while blood pressure is being monitored. So if the blood pressure is more than 150 systolic, you need to start pharmacological medications. So firstly, for the bladder, as I mentioned earlier, look at the catheter tubings if there's kinks, folds, or overfilled. But if the patient comes in with no catheter, we need to insert the catheter, but not like usual procedure. Importantly is we need to use a 2% lidocaine or lignocaine, whatever available at your setting. So you need to introduce it at the urethra, but wait for 3 to 5 minutes first, and then introduce the Foley's catheter. So whereas if the patient's already on a catheter but it's blocked, so you just need to irrigate with 10 to 15 mils of normal saline, and but not continuous irrigation, and still blocked. Despite after irrigation, we need to remove the catheter and replace a new one. So avoid repeated flushing because it can actually worsen the distension. Whereas for the bowel, so as I mentioned earlier, if the blood pressure is more than 150, you need to treat first because in order to do a rectal examination, we need to lie the patient. So you can't lie the patient in AD. So you need to treat where I will explain what kind of pharmacological agents next in my next slide. So once you have treated, blood pressure comes lower, more than lesser than 150, then we can look for the bowel impaction. So you have to do a per rectum examination. So before you do a per rectal examination, same, use the lidocaine or lignocaine gel. Apply it copiously. We don't need, you can be very, very, how do I say, generous. Apply it over the rectum, then wait for 3 to 5 minutes before your digital rectum check. Yeah. So if there is impacted bowel, you need to remove gently. But while doing this procedure, you are also checking the blood pressure 3 to 5 minutes. And if the blood pressure increases, stop first. So wait for the blood pressure to come down and then you gently remove again. So remember, if the AD worsen, that means the blood pressure or either the symptom worsen, you have to stop doing the rectal per rectum examination and removal of the impacted bowel. So third, as I mentioned earlier, you've checked the bowel, you've checked the bladder, you've checked the skin. Despite managing, so usually when you settle the bladder or you settle the bowel, these two are the most common thing to cause AD. Automatically, the blood pressure actually will come down. This is very, very, it's like miracle. It does come down. But let's say persistently, the blood pressure is high, more than 150, 150 or more than 150, and the symptoms still persist, then the patient warrants a pharmacological management. So what kind of pharmacological management is as per this table? Of course, this is by the guidelines. So we don't have a local guidelines. So this is an international guidelines, but we will look to what is available in our local setting. So first line is always GTN. Yeah. So GTN, unfortunately in Malaysia, we don't have a paste. We have spray and we have our sublingual. So we just put it sublingually, or if you have a spray, you spray it because spray is even fast acting. And then, so you wait, the onset of action is about 15 to 30 minutes, and then the total duration is 7 hours. But let's say the blood pressure drops, and then patient is also asymptomatic, you can actually ask them to spit the GTN out. So that is where the GTN actually is superior to anything else, because you can spit it out, or if there's a paste, you can wipe off the paste. Yeah, so this is where GTN being used. But always remember, before we start giving initiating GTN, always remember, if inquire from the patient if they have taken any PDE inhibitors, that means phosphodiesterase inhibitors 5, because they do take, like example, Viagra, sildenafil or tadalafil for their sexual dysfunction. So if patient has taken this before coming to emergency, so this is contraindicated. So very, very important, because it can actually reduce the sudden drop in blood pressure when they are these two medications being combined. Second agent, captopril, I think we still have it in our emergency setting, in our KKM setting. So it's 25 mg. You give them stat. I'm not sure whether in our emergency setting we have clonidine. We can discuss this later. Hydralazine is in IV form. Nifedipine was my favorite medication before, but I think unfortunately we don't have this now at the current setting. It's been removed, I think. So we commonly use GTN still, and second agent will be captopril. All right. So there's action of onset. The onset of action is very, very actually 15 to 30 minutes, or most is 15 to half an hour. Yeah. Rarely anything is 1 hour except for the clonidine, and their total duration of action is about 7 to 8 hours. Okay, so we have to be cautious when we have initiated pharmacological medications. So when we start, and the threshold is actually for this. So in adults, anyone with systolic blood pressure more than 150 or more than 150, we can start. For children under 5, the systolic BP to initiate pharmacological medication is 120. Children 6 to 12, 130, whereas adolescent is about 140 mmHg. Yeah. So when we start this pharmacological medication, remember closely to avoid rebound hypotension. Yeah? So they need close monitoring, which is 3 to 5 minutes continuous blood pressure monitoring. And the blood pressure need to monitor it for total of 2 hours. Okay. So remember, as I mentioned earlier, when they come into ED, these are the red flags that we always must be aware. Hypertension, bradycardia, and all those symptoms. So please treat as ED until proven otherwise. So common things are always the bladder. Secondly is the bowel, and then the third, like musculoskeletal, and or even but I've had experienced cases where we've ruled out all these 3 common causes. When you do an ECG and all, patient is actually having an MI. And throughout during my master's years, there was also a patient with cholelithiasis. So these are all things that we have to look out after ruling out all the 3 common triggering factors. Yeah. Okay. So what should we do after we have initiated pharmacological treatment? So as I mentioned earlier, check the blood pressure 2 to 5 minutes until stable. Unfortunately, they need to be observed in ED for 2 hours and slightly more for recurrence of AD or hypotension. So you can't just discharge the patient immediately after the blood pressure drops and you've sorted the cause. Please don't discharge the patient immediately. They can have hypotension at home or they can have recurrence. So please keep them at least at the observation bay for about 2 hours. All right. So, and please also don't change the posture after you have started treatment. So always keep them upright. And documentation is very, very important. Also document what was the blood pressure like, what was the treatment given, and the trigger, so that there's a documentation and the next team, or there's a follow-up, so we know what the patient has came for AD, what was the cause, and the other teams can actually advise in detail during the next follow-up. So this is just to quickly to mention this. Of course, not much relevant in ED, but of course, in certain district region, you do see patients, pregnant patient or coming in labor. So ED can mimic preeclampsia, but how to differentiate it is in preeclampsia, the patient will have constant hypertension and proteinuria, whereas they also can have ED when they are in labor. So how to differentiate it? But they will have hypertension only during contraction. So while there's no contraction, the blood pressure resolves in between. Yeah. So how to lower the risk in those patients with with pregnancy or labor, especially in the female spinal cord injured patients? Epidural anesthesia actually lowers the risk. So what not to do, or the common pitfalls that that we always do when the patient presents to ED: do not lay the patient flat, worsens the blood pressure. Avoid long-acting hypertensives, means like ACE, beta blockers, or even like calcium channel blockers, please, except for the nifedipine, yeah. And then don't miss bladder obstruction. That is the most common cause, and also overcorrecting the blood pressure, which can lead to severe hypertension. So when they have severe hypertension, then we have to start fluid resuscitation. So that is the same management for anyone with hypertension. So what are the complications if we leave anyone untreated with AD? So it is very, very common and unfortunate where they actually have intracranial hemorrhage or stroke, myocardial infarction, arrhythmias, seizure, pulmonary edema, retinal hemorrhage, or even detachment, and even death. Yeah, so throughout my experience as a rehabilitation physician consultant for this 8 years, including my medical officer years, so it's about more than 12 years, I've actually seen 3 cases where one of our spinal cord injured patient went for a procedure and ending up with stroke, whereas two actually suffered from death due to those days low awareness and in the hospital who's been treating him, so the patient actually succumbed to death. So how to prevent? So let's say patient has been in ED, undergoing AD treatment and all. Please, I would advise, to just educate the patient. I understand ED situation and ED setting is very busy, but just take a very short time of your patient care just to advise them on the bladder bowel care and on the pressure injuries, and then educate the caregivers. So sometimes patients, they do tend to forget or overwhelm with a lot of information. So caregiver education is important, and then also inform them the emergency action plan. If this happens again in house, they need to come back to hospital again, and best is to have a BP monitoring at home. And if they have a recurrent AD, we can actually, so if they are going for some procedures, we usually give prophylaxis. Yeah. So, and let's say in emergency setting, patient has actually been treated for AD, the best is actually please do contact any of the rehab physician on call so that you can inform the patient and communicate with the rehab physician what to do next, so that there's a teamwork and you're not just treating the patient alone. All right, we always appreciate a teamwork, so that's very, very important. So to wrap up the case discussion that I mentioned earlier, so what actually happened was the ED team managed to recognize the AD promptly. The main trigger cause for the catheter blockage, it was relieved, and BP normalized within minutes. It's actually really true. Once you have found the triggering factor or the cause, and you have evacuated, you have managed it, your BP normalizes within minutes. Rarely throughout my experience that I have started pharmacological treatment. Yeah, very, very rare. So please monitor patient for 2 hours for any recurrence or hypertension, and also educate them on the trigger avoidance. And please do give us a call to the rehab team who's on call, and you can get an earlier rehab clinic follow-up so that the patient does not miss the follow-up, or we can see the patient earlier to further investigate and educate and manage the patient further. So key takeaways for emergency physician. So always suspect autonomic dysreflexia in hypertensive SCI patient, especially T6 and above. Elevate the head and remove the trigger first. Treat the blood pressure if the systolic blood pressure is more than 150 and equal or more, or symptoms persist, and monitor the blood pressure continuously until stable. So remember, 3 to 5 minutes you got to monitor for 2 hours, and document and educate before discharge. So the learning points I would like to summarize is AD is a preventable medical emergency. If we recognize it early, actually it can save life. And the pathophysiology is the unchecked sympathetic discharge. Yeah, so just remember this, parasympathetic and sympathetic. Whereas the management is stepwise and trigger removal. Very, very easy. Nothing very difficult about it, but we need to be aware what are the common triggers. And of course, prevention is continuous education and collaboration with the team who is managing the patient. So my talk today, the references I used is since I mentioned this, we don't have a local guidelines yet, CPG. So commonly we use our Paralyzed Veterans of Americas. SKYR is our evidence-based medicine for spinal cord injured patients. And these are the textbooks that we use, still in relevant and articles. Whereas, okay, so we can, I think I'm towards the end of my talk, and I would welcome any questions that from the floor, and maybe we can share any experiences from the EPs here, or any question that you all have came across patients having AD throughout your career. Thank you.
Okay, thank you very much, Dr. Anis. I think it was a wonderful talk. A lot of relevance to the emergency department setting. So definitely, I think we have a few questions, of course, some pertaining to the principles of trauma management example, lying the patient down or sitting the patient down in early trauma. We will discuss that later. But
Yes.
I think the take home, I think for us EPs is integrating AD in spinal cord injury patients. So we are very interested in the bone, on the broken bone, on the paralysis. But we tend to forget, or maybe even for me, to consider AD, and bladder obstruction as a cause of like the case scenario just now. So it's an eye opener for us as well. We are busy starting, IVI medications, trying to get nicardipine in bradycardia hypertensive patients, but we overlook the bladder. So I think things like these are very interesting. But just to add before we go on to the next topic, we don't have clonidine or hydralazine in the
Okay.
emergency. But one more thing, instead of example nifedipine or GTN, they will start nicardipine because of the IVI nicardipine, because of the bradycardia, and then they are worried about the brain bleed, so they might not start the GTN. Maybe they would add nicardipine over there. But we can discuss some other questions later. So I think thank you very much. Very eye opening. And we go on to the next speaker before we
Gurjit, can we finish
Yes.
the whole session with the question, because I think probably people will forget.
Oh, okay, sure. Okay, all right. So we go on to the questions first. Let's go to the chat box first. So we have a few questions in the chat box. Can this AD happen in incomplete spinal cord injury? Very interesting question. What do you think, Doctor?
What do you all think?
I think for me, I think yes. Yes, of course.
Yes. So as I mentioned earlier, of course, complete has higher risk. 90% they can present with AD throughout their first year. But incomplete, as I mentioned, T6 and above, incomplete, the risk is also there, 15 to 30%. Whereas incomplete T8 to T12 can also have, but of course at a lower chance. Yeah, but can have.
Right. How acute is the onset of AD? So I think from your talk just now, it can happen acutely and resolve acutely also, isn't it?
It's like zip up and then down again. Yes.
Right. Okay.
Sorry, I think can I ask one question? I think what it meant is how fast from getting the spinal cord injury for you, I mean from that moment that you have the injury to the development of AD. Like, do you need, because usually if we see a patient with a complete spinal cord injury, they're usually coming with hypotension and bradycardia, right? So I think that's what the question meant for, I guess.
Okay, all right. So no worries. I will answer for both. So if let's say the presentation of ED, how acute, that means, of course, there's a, let's say a patient's in ED, I mean a spinal cord injured patient's at home, and then he suddenly have the symptoms. So it as common as a kinked indwelling catheter. So the patient can actually have the symptoms within 5 to 10 minutes. You just need 5 to 10 minutes for the patient to have symptoms. If it's a kinked bladder or blockage or even an infection, hemorrhoids and all that, all right? And once you settle the triggering factor, the blood pressure and the symptoms also come down acutely. To answer the second part of the question, possibility where how early can a patient after sustaining an acute spinal cord injury present AD? So number one, once the patient is out of spinal shock. So if the patient comes in and still in spinal shock, we would not appreciate them having a AD because the blood pressure is low. So, you know, many of them actually miss this as well. A very good question. So, so not necessarily anyone with spinal shock not having AD. They do have AD, but it's a bit difficult to identify because of spinal shock. The blood pressure is low and all that. So you don't see the high blood pressure. You don't see the hypertension or high systolic pressure, whereas you have to look into the symptoms of the patient. All right, so that is where in the early case or early scenario. So that's why very important when the patient is still in when a patient is acutely admitted for a spinal cord injury and patient still in a spinal shock, of course, you know, the patient's in emergency not very long. But this, we encounter this a lot of times in ICU, in the critical care, where everyone overlook the blood pressure because it's low, but patient's been having the symptoms. Yeah, so always the managing team always need to make sure if the patient being referred to rehab early, the most common thing that we always look into is the bowel, bladder, and skin management. Yeah, so that is important. Whereas if the patient's already out of spinal shock, then let's say the patient came in not in spinal shock, fortunately not in spinal shock. So the onset is very early as well. They can have it any time of, even within the first few hours of spinal cord injury, after having a spinal cord injury. Yeah. I hope I answered this question.
Thank you, Doctor.
Yeah, that's new thing for me. Can I ask one question if you don't mind?
Yeah, sure.
Yeah, so you mentioned about if you're having difficulty in managing this situation. I know rehab physician, quite a number of them, they are very kind people, very appreciative, let me call them. But unfortunately, not all hospitals are equipped with rehab physicians.
Yes.
So what would be your advice? I mean, I know there are few EPs here, so do we go to the rehab physician who is in charge in the cluster, or what's your opinion on that?
Yes, exactly. So since we have the cluster system at the moment, right? So really, I mean, you know, it's very helpful. So please do contact the cluster physician, the physician at the lead hospital in charge of the cluster hospital. So we are welcome, we are always welcome to receive call and help to manage the patient collaboratively, yes.
Okay, I have a question. Is it okay?
Yes. Go on,
Okay.
Dr. Gurmeet.
Right. The principles of trauma management is to immobilize the patient, don't make the patient move. So I have this special interest qualification in trauma as well, where they mentioned to us in trauma patient, early onset trauma patients, we don't move the patient, we lie the patient down, the patient's on spinal cord. Even after that, when we find out the patient has got a spinal cord injury, then the principle of management is to lie the patient supine, not to move the patient too much, not to displace the fracture or cause spinal cord compression. But one of the way to diagnose that you have mentioned is you should not lie the patient down, isn't it? You have to sit the patient.
Not manage, not diagnose, to manage if the patient has AD.
Yeah, so how would you go about that? In spinal cord injury, you are not supposed to move the patient, you're supposed to lie him down flat.
Yes.
But to manage this AD, the patient should be propped up or
Okay.
to sit up. So there is a difference in the principles there.
Okay.
How would you advise?
So as I mentioned earlier, the common factors triggering AD is impacted bowel, bladder which has not been drained. So when a patient comes in acute trauma, of course the early resuscitation protocol is inserting a catheter. So you've already settled that. So to trigger the AD, unlikely in that situation to trigger the AD, unless the patient has got constipation. Pre-morbidly, patients got constipation and all that, so leading to AD. But rarely we do see that in the very, very few hours of sustaining an acute spinal cord injury for the patient to have AD due to bowel as well. So usually it's the bladder, commonly it's the bladder. So when in that situation, you can't elevate the patient, you can't prop up the patient, but it's okay since you've put in a catheter. So the AD symptoms rarely happen in that situation yet. And of course, the patient goes for early surveillance, primary, secondary surveillance and all. Then you've already put the collar. So I think in that sense, so when the patient's on a collar and propping up the patient slightly, at least a 45 degree is still not detrimental.
Maybe a tilt rather than prop up the patient.
Yeah, not prop up like up to 90.
Tilt the bed up.
So of course, just a 30 to 45 degrees of tilt. Yeah.
Right. Okay.
But of course, in a chronic spinal cord injury, when they come in with AD, 90 degrees prop up is what is recommended.
Or 90 degrees, huh?
Yeah, at least how much they can tolerate. Yeah.
Right.
Yeah.
Okay, thank you very much for the clarification. We open the floor. Any other questions? Anybody? Okay, I think if there is no other question, thank you very much, Doctor.
Thank you,
I think
Dr.
very enlightening talk for all of us. Really, we can practice in our setting. So, thank you very much. Very relevant.
All right, and thank you, and thanks for the invitation. And have a good day.
Thank you.